Well, we're going to go ahead and get started. As you can tell, I still have a little bit of a punchy voice. Last time I was in this meeting, I had some kind of sinus thing. Well, it migrated down to the lungs, so lucky me. This one I'm going to do kind of that way, but that's okay because by April, it's all going to be good, right? Okay. So just introductory things. This is our Roar RX meeting for March 11th, 2026. And basically, we are going to go over a few just business items, and then we're going to welcome our guest speaker. So the last day at ISU for dropping a class with a W is March 20th. So keep that in mind. If you're not on the ISU campus, check with your academic calendar on your campus to make sure that you know about that date. Hopefully we don't need that date, but just so you know, it's out there. We're going to have spring break the 23rd through the 27th this month. So I hope everybody has some good plans. I'm actually going to go somewhere if I'm not sick. So we'll see. And for those of you not on this campus, check your calendar again. I hope you have some fun. I'm actually going to be in Boise this weekend. So Friday, 3/13. I know Friday the 13th, but for me, that's probably lucky. So for any of you that are over on in the Western Idaho side of the state, for those of you online, I will be over there on Friday at a HOSA event at the Boise State campus. Can be there earlier on Thursday afternoon. So if you wanted to stop in to the Meridian campus and join me there, get a tour a little bit, feel free to reach out to me. So email me first and let me know so that I can plan on meeting you there. Last call for fall 26. So for anybody planning to join the PharmD program in fall 26, no, April 1st is our hard and fast deadline. So if you're still just kind of working those last details of your application, or if you're stuck on something, or if you thought you were finished and for some reason it's not showing up as verified, please let me know and then we'll get you over the finish line. The fall schedule is viewable on the 16th, so that's next Monday here at ISU. Again, at other campuses, check your calendar. That means we can see it. We can't just register until the April 6th date, and that's like seniors, graduate students. So again, early April, we'll be looking at putting those schedules together for your next semester if you're needing one. So if you need my help with that, let me know anytime after the 16th, preferably before the 6th. That way we can go ahead and get that all set up. So when your first day to register comes, you just pop those classes in and we'll be ready to go. Yeah, and our next meeting is going to be 4/8, and that will be our last one for the spring. So we will have a PharmD student panel that day. I already have 3 really great PharmDs signed up for this. So I would encourage you to think of questions that you would have for them for our next meeting. All right, any questions before we turn to our guest speaker? All right, well, I'm going to introduce Sister Serpa. I said that wrong. She is a professor with us here at the College of Pharmacy, but she has a wide variety of pharmacy experience, including cardiology and family practice. And so I'm just going to invite her up to kind of share with us about her pharmacy path, and then unique things about those different kinds of practice.
Well, thank you, everyone. Some of you I've seen around, some not. So again, Sister Michaela, I have a hard time convincing students and others that they can call me by my first name, Sister Michaela. So I actually am an alum of ISU as a pharmacy student. So I grew up here in Pocatello. I went to Montana for my undergrad and then came back to ISU for pharmacy school. So I tell people I'm a professional drug dealing nun, and they usually like that. So when I first graduated from pharmacy school, I actually went out to Connecticut, and there I practiced in a couple hospitals. They were medium to large size for about 12 and a half years. So if you have questions about like what does hospital pharmacy look like, I can answer some of those as well. And then I taught in North Carolina for about 2.5 years before coming here. And I've been here a little over 2 years now again. So it's a pleasure to be back, and the students are awesome. So I love it. Since being here, I was at a cardiology clinic in Idaho Falls for a bit, Idaho Heart. It's probably the largest cardiology office in Eastern Idaho. And then most recently, I moved to a local Health West family medicine clinic. So I'm seeing patients there for a whole variety of disease states. I did a residency. I don't know if you're familiar with pharmacy residencies, if you've had anyone present on that. It's a advanced training essentially. So once you finish pharmacy school, you get your license. Prior to that, you're applying for residency and interviewing, and there's a matching process. So after you apply, you might get invited for interviews, you might not. So it's very competitive. And then there's a matching process at the end to identify, did you match with a place or with a program? And then you go there. So I did a first year residency. I did not do a second year residency. Back when I was doing residency, there weren't as many second year. The second year is often when there's a specialization. So oncology or pediatrics or any of the different specialties of doctors you can think of, most of those, we have something within pharmacy, infectious disease. So I didn't do a second year residency, so I have experience in a whole lot of different areas. And within the hospital, I did a few different things. So there are clinical roles in the hospital where you're rounding on the unit with the providers, going into patient rooms, speaking with them. One thing that's interesting in the hospital is that the provider, and most people don't know this because we kind of blend into the background. But when the provider orders a medication, the nurse can't access it until we approve it, or verify it is often the word we use. And so we are a major stopgap, that when we're looking at that order, we're looking at what their labs are, what's their past medical history, what other medications are they on, what tests have been done, have the results of those tests come back, and does that influence whether we think this is the right medication? We're that stopgap. And if we don't approve it, it's not going to be given to the patient until we've said, yes, this is actually a good medication. And most people don't know that. They don't know the role that we play in that regard. There's also a pharmacist in every ICU, and it's pretty much required for accreditation because we decrease mortality for ICU patients. We decrease length of stay in the ICU. So people are there for less time and they get out alive, not dead. So that's the impact that we have. And most people who are in the ICU had no idea that a pharmacist was right there sitting with the nurse, sitting with the provider, and the impact that we make on patient safety and outcomes. So and there's data for that in a lot of different areas. For example, every transplant team has to have a pharmacist. It's mandated, required through the transplant program that a pharmacist must speak with each patient, must go over medications, and must be on the decision-making team. So it just kind of gives you a sense of the ways in which we're able to integrate and be a collaborator in the team of people taking care of the patients. And we have a distinct and unique role in doing that. In the outpatient setting, especially here in Idaho and soon to be hopefully Alaska, the role of pharmacists is really expanding and the limitations reducing. So in Idaho, the laws really allow us to do almost anything. We can diagnose, we can prescribe, we can get insurance approval through Medicaid and private insurance companies. A barrier is still the federal Medicare system, but there are some ways to work within that. So as a university, we're really working on how can we promote pharmacists diagnosing, prescribing, and really functioning at the extent of our license and our training. And we're like the first state to do that in the whole country. You know, Dr. Adams is giving presentations all over the country at national conferences to tell them what we're doing because they want to copy it. So we're like right on the front lines of where pharmacy services are really expanding and making an impact. And this is particularly important in our rural areas where access to providers and mid-levels even is decreasing. So we got to step up to the plate and we can provide that. So right now in the clinic I'm in, I'm seeing patients for diabetes, for hypertension or high blood pressure, for cholesterol disorders, so all sorts of metabolic disorders. But I'll also get things like, my patient is all of a sudden having a lot of dizziness, and I'm not sure if it's medication related or if it's this other thing, and she has a ton of medications. So can you review these and see the patient, talk to them? So sometimes there's kind of the one-off of they need our medication expertise in a really complicated situation that they don't, most of the time don't have time actually to deal with. So they're very grateful that we're there. They refer people very quickly, and the ones they refer are the ones that are the hardest to take care of. And I'm happy to do it. And I've really loved being at the clinic that I'm at now. So maybe I'll just open it for questions. That's kind of a broad overview of some of the clinical services. You're probably more familiar with the dispensary services that we do in the hospital or at CVS or a community setting. So anyhow, do you have any questions? Or open in the middle.
I ask one? I'm on the Zoom.
Yeah.
For the residency, the 1 year, potentially 2 years that you talked about, is that our 4th year of education or is that after the 4th year?
Good question. So that is after your 4th year. During your 4th year, you're still an intern. So the extent of what you can do is limited to what your intern license permits. As a resident, you're a full-fledged pharmacist. So everything you're doing is on your license. The benefit of it is that as you're moving into these more complex settings, like seeing a patient in the ICU, they're really complicated. And we provide a very good basis of education within the pharmacy program. And our NAPLEX pass rates are very good. But there's also a degree to which we can't get there, right? There's a detail and a complexity that we can't always get to within the 4 years or expose every single student to in those 4 years. And so that's where the residency is helpful, is that you're moving into a professional role, but you have lots of mentorship. That's why I like residency, because I feel like if you're going to a community setting, of which there are community residencies, I would say a lot of what we provide in pharmacy school makes you ready to move into a setting like that, by and large, of course. But some of these other settings, I think you're going to encounter things and even medications, we can cover a broad range of medications, but there's going to be ones we can't get to within the 4-year program. So residency provides a very mentorship setting for you to move into your pharmacy practice and really prepare you then to be an independent practitioner. So I don't know, does that answer your question?
Yes,
Okay.
thank you.
And you're paid a little less. We're still paid pretty good. I think most residencies, are between $40,000 and $50,000 a year. So it's kind of a pay cut up front, but by and large, if you've done a residency, the jobs that you can get into, if you stay in that job, you're going to make more than if you hadn't done a residency because of the job opportunities. So in most programs, the first year residency is a general residency. So mine was in a hospital. So mine was pharmacotherapy, essentially. So I rotated through different areas in the pharmacy. So general medicine, surgery, pain management, infectious disease, ICU. So you rotate through all these areas, but again, you're functioning as a full-fledged pharmacist, but you have a mentor to help you. You also get into what are some bigger projects we do, in the in the hospital. If there's a new drug that comes out and a provider wants to be able to use it, they have to submit a form that says, I'd like to have this on our formulary. And guess who does that full review is pharmacy. And then we present that to the P&T committee and we say, do we think this should be added or not? And most of the time, whatever we say, that's what they do. So we have a really big role in that as well. So as a resident, maybe you do that. Maybe you do a more extensive research project because you have to publish something. You have to do a poster, you have to publish a manuscript, or at least write a manuscript. So maybe you're doing things in a bigger, more intensive longitudinal way that just isn't possible within your API rotations. So yeah, that's what I did mine on. Now, some are 2 years. So like the family medicine one here is a 2-year pharmacotherapy. And so there's some that are 2 years. Some move from first year to second year. So like, let's say that you're really interested in transplant. I would generally suggest to someone who's interested in a specialization is find a place that has that and do your PGY1 there. PGY1 means post-grad year 1. That's general terminology for first year residency, PGY1. So do your PGY1 at a place that has that, because you're going to have early access to applying to the second year in that category. And if they like you, they're definitely going to take you. So you don't have to do the whole matching process for your second year. So, so as you're going through and you're learning these different disease states, really be thinking about, is there one that I really respond to? And it might be one you wouldn't even think of. You might think, why would I want to do transplant? But then you get in and learn more about it and you're like, I do respond. So be thinking about that, because you do want to be kind of considering that before you get to APPEs. Because by the time you get to APPEs, you really need to be looking at what programs have it, at putting your application in by that fall, and that sort of thing. So oh, your 4th year rotations are called your APPEs, Advanced Pharmacy Practice Experience. So the 4th year students who are doing their rotations with us. So, and I have one in clinic, so he sees patients with me. He does education, he does blood pressures. If it's someone we've seen before, we have a patient coming today. She just got a new injectable medication. So, and she wants help learning and knowing how to do that. He's going to do the whole thing. I'm not going to do any of it. So we try to give a lot of hands-on experience. Any other questions? Yeah. As a PGY1, like as a first year resident? Oh, as a pharmacist? That largely depends. Oh yeah, sorry. The question was about how much of your time is spent preparing and doing presentations or research, probably in general. Research happens primarily, I would say, either if you're in academia, so you're a faculty member, or if you're in a hospital setting. Less research happens like at the community pharmacy level and at the ambulatory outpatient pharmacist level. What percentage of time, like in an academic situation, my contract dictates 5% of your time is dedicated to research, or 10% of your time is dedicated to research. So it's actually in our contract what amount of time is going to be expected for that, whatever that task is. In others, it's going to be, if you're really good at it, they might say, hey, we're going to offload you. We're going to take you out of these 2 shifts. And those 2 shifts spend that time working on this formulary review or this drug class review. As a resident, they don't take you off anything. That's just part of it. So your first year is going to be intensive. It's a lot of time. It's a lot of experience. But thereafter, it would depend on if they need you to do more, they're going to make time available for it to help you in that. And also there are leadership roles. So there's a whole slew of leadership within pharmacy. Let's say that you didn't go into pharmacy loving the clinical, you're willing to do it, like it, but maybe you really like computers. There are IT pharmacists. They don't do anything with drugs or clinical decision-making. All they do is run computers, and they run programs, and they design pages for the EMR. Like that's all they do, for example. So, so the spectrum of pharmacy jobs is huge. And then there's all leadership within the hospital, within the outpatient, where like, let's say you really like business and you thought, well, maybe I want to open my own pharmacy. And maybe it's just not feasible for you right now. Well, you can go into management in a hospital and you're managing full drug supply and accessibility for that whole hospital. And the pharmacy budget is the second largest budget in any institution. The only other budget item that's bigger is salaries. So we manage a huge amount of budget. So if you like business and you're in the right place, because you can do it within pharmacy. And you got to know the drugs and understand them because you're deciding, how are we going to switch one out? How do I decide which contract I want to take? So our expertise in medicine is still necessary for those jobs. Only pharmacists can have those jobs. So if you have other likes and things, you might be able to really use your other skill sets in a whole variety of pharmacy jobs that are available.
Medical residents.
You don't get questions.
Medical residencies are kind of notorious for like long hours and just kind of, crushing workload. Is it like that for pharmacists?
Well, both medical and pharmacy resident, the question, sorry, was how crushing is a residency time and workload. Medical residents as well as pharmacy residencies have had a lot of laws put in place as far as time requirements. And so they're kind of wussy now. When I was there were no rules. So you worked 12-hour shifts times 7 and then did your projects on your own time, things like that. So now it's much more doable. There are limitations on what they can expect, like with you at the facility, as well as time expectations outside of that. So it's very doable now. I mean, it's pretty easy. It's easier than what some of our pharmacy jobs are actually, because when it comes to your pharmacy job, there's no rules. They can have you do as much as they want. So it won't be too much. And your preceptors will be nice, help. Any other questions?
Talk a little bit about what the difference would be for cardiology practice. Is that
Sure. So the question is kind of how does practice differ when you have cardiology as a specialty or really any specialty? Generally, to go into a specialty like cardiology, you would have had to have a PGY2, so a second year residency in cardiology. I got around that because I have 12.5 years of experience in a huge hospital in the West Coast where I did a lot of cardiology. So my experience substituted for, a second year residency. But what you would do in a cardiology office would be in an outpatient would be similar to what I'm doing now. It would just be cardiology disease states. So you might take heart failure patients. You might take patients who need a heart transplant and because their heart is so bad. But you could manage anticoagulation. I did a lot of anticoagulation there. Their warfarin program was a disaster because they'd never had a pharmacist help them with it. And so we went in and we totally redid that. And within 4 months, they had 20% increase in touch points with patients in 4 months. And the nurse I was working with was like, oh, I've never known to do it this way. And so anticoag, it would be a big place. But seeing them, those patients have a polypharmacy is what it's called, lots of medications. So they're grateful for any review of medications, seeing patients and things that we can do. So, yeah. And that would be true with us in any outpatient clinic, like any ambulatory clinic would be for us to see patients. And sometimes we could do a co-visit where we go in with the provider. It could be where we go in before the provider and then they come in after. It could be that they see the provider and they're a mess and they say, we want you to schedule with Sister Michaela. And so then they schedule with me and I see them after that. So the patient encounter mechanism happens in a variety of ways. Anything else?
What is the scope of practice for diagnosing and prescribing? You mentioned metabolic disorders. Is it fairly limited to kind of that window of things, or what is the scope?
No, the way the law is written, and don't quote me here, but by and large, it's written exactly like the medical law, which is you can diagnose, prescribe, and all that to the extent of your license, according to your area of expertise. So if you know metabolic disorders, then you have the ability to diagnose, prescribe, monitor labs, etc. If your specialty is in pain management, then you have the ability to do that. If you like, I have kind of broad experience, so I could do some infectious disease. Like if you have a UTI, like I can routinely do that. I'm not going to read a chest X-ray. That's not my expertise, right? But I can read what a radiologist said was your chest X-ray and make decisions off that. That is within my expertise. Like if you in fact have pneumonia, I can help determine what's the right medication for you based on all these factors, disease states, etc., history. So it's all within your area of expertise that you can do any of those things, which is the full extent of your license.
Thank you.
Yeah, and again, that role is expanding. 4 years from now, it's going to look really different than even what it does today. So the lack of providers, of physicians and mid-levels is going to result in an absolute need for us to be available and to help with these things. So it's going to be undeniably a role for us. So for us to teach our students how to diagnose is really important. And not all pharmacy schools incorporate that, because that's not what their pharmacists are doing very much. But we are looking future. This is what it's going to look like. So we need to make sure that you have the skill set to do it. So that's a big discussion for us of how do we continue to incorporate more and more diagnosis into the curriculum of how we train you. So
How does that work with the doctors? Like, how does that actually work in a facility to have pharmacists sort of interact? I mean, I suppose some doctors are more receptive than others.
Mhm.
What does that look like?
I can tell you what it often looks like and what it could look like. So what it could look like is that you're in the office just like a PA or a nurse practitioner, and they refer their complicated patients, and then you diagnose, manage, prescribe, change the doses, monitor, like they're your patient. So that's the potential of what this law allows for. And there are some places where it looks a lot like that, actually, depending on the clinic. So we have to consider, what are the providers used to, and what do they understand of pharmacy services? Most physicians who, let's say in the last 10 years, have, I would say, grown up with pharmacists. So when they did their physician residency, well, there were pharmacists on rounds with them. So they got to see firsthand, how do we support them? How do we help them? What's our expertise? Why should they trust us? And so those providers often are much more open to pharmacists entering in these roles. Some of the older ones, we're still working on them, the ones that are ready to retire, and they'll retire by the time you're in there. So, and also we're working with organizations to develop policies that are in line with the expanding pharmacy services. And that's a little bit of a slower process, and we're working on that. Some facilities will have a policy, even though we're allowed by law, some facilities will have a policy of, no, you can't be the sole provider. They have to have someone else. Is that required by law? No, not necessarily. It's going to happen because there's certain things I don't have expertise to do, right? But often what it looks like now is a real collaboration. So like the providers that I'm working with, like I'm going to start medications and change doses, but I'm also going to communicate it to them, right? And just make sure we're all on the same page, which is what we want anyway. So that's more what it looks like, right now. But you know, like my patient, she had a clot 5 years ago and it wasn't in the chart. Or one had a history of pancreatitis. It wasn't in the chart. So yeah, I'm putting it in there because that diagnosis needs to be in there. And if they have a diagnosis of prediabetes, but now we're looking at an A1C of 8, I'm going to put in the diagnosis of diabetes, and there's no problem with that. And that's technically diagnosing, right? But I mean, anyone can look at an A1C or a blood glucose, fasting blood glucose, and within the guidelines make the diagnosis. It's not rocket science. So, so we should put it in there, and they're fine with that. So, anything else? Well, hopefully you're excited to be pharmacists because what we get to do is awesome. And we have a really unique role. We have a unique way of approaching it, of doing it. And it's not contrary to what the physicians and mid-levels are doing. It really complements it. And it really improves patient care to have us all working on that patient, on a patient, which has been proven time and time again. So, so yeah, hopefully you're excited to do this.
More excited than the book.
Well, I'm sure there's a little tremor as well.
Anxiety maybe too.
Thank you so much, Sister Michaela, for
Give them
joining
my
us.
contact if they have questions. You can email or text me or call me.
All right. All right. I'll put that in the email that I send you all with the video. So thank you so much for coming. All right. Well, oh, and I left my papers over there. Hey, any other questions you have for me at this point in the game? Right. Well, thanks for coming. Don't forget about our next meeting. It's our last one for this academic year. April 8th, I will send a reminder. But we are going to have our PharmD student panel that day. So I think it's current, can't remember if they're P3s or P2s. But they're a little more advanced student. So we have 3 of those coming that I know of, but we might have more. I know they have a little bit of a break at noon on that particular day. So we lucked out. So write down a few questions before you come on the 8th so that you have some things to ask them. Because they'll tell you about, you know, their experience and where they are right now and where they're planning to go. But it's really helpful if they can take your questions and just answer anything that you have curiousness, you know, you're curious about how they manage time, how they manage working and being in school, all that stuff. So feel free to bring your questions. All right. If there aren't any questions for me, then we're going to wrap it up early today. Okay, everybody can go have lunch. Okay. All right. Thanks again. Talk to you later. Bye.
Thank you, Linda.
Thank you, Betty.
Thank you.
Thank you.